Assalamu alaikum wa rahmatullah, everyone. I hope you all are doing well. My name is Abdallah Kharsa. I'm a second year. Inshallah, today we're going to be covering hepatobiliary physiology, which is basically the two physio lectures you have with AGR and GIT. So here's my contact information if you have any questions after the session or whenever. طيب. And let's get into it. طيب. So the first concept I want you to keep in mind is that proteins and fats are digested differently. طيب. This is a protein, this is a fat. Okay, why is this? You're wondering. This is because lipids are not water soluble. Lipids and fats, same thing, brother. Okay, as you can see in this water bottle, you can see that lipids do not mix with water. Like, so due to this, you have a few problems. So, due to lipids not being water soluble, they need something else to be digested on top of enzymes. They need enzymes, which are lipases in the case of lipids, and they need something else. What is that? Lipids on top of lipase enzymes need something called bile acids. And bile acids are basically going to be the main topic today. We're going to be really talking about what do bile acids do, how you make them, how they move around, everything about bile acids. Right? Now, why do you need bile acids? We said because lipids don't mix in water. But you need something that is both hydrophobic and hydrophilic in order for them to be soluble in water. Because the hydrophobic side can basically surround the lipid because it likes lipids. It doesn't like water. It's hydrophobic. While the hydrophilic side, the side that loves water, can face the water, and then you can have lipids which are basically water soluble. طيب? So bile acids are produced in the liver, released in the small intestine. We're going to be talking about this in excruciating detail later on. Okay. So what do bile acids do? As we said, they take this fat globule right here. It's basically lipid soluble. It's not water soluble. You can't digest it with enzymes directly, and it does something called emulsification. It emulsifies it. It takes droplets of it and surrounds it. As you can see, this is the hydrophobic part, and this is the hydrophilic part facing outside, and emulsifies it, breaks it into smaller pieces, thus mixing it in the water solution. Okay, so you have the hydrophobic part inside, hydrophilic part outside, and now it's water soluble. Okay, so they emulsify fat droplets. It also increases the surface area, so it actually also makes it easier for the enzymes to act. Think about it. If you had enzymes acting on this whole thing, it would take longer than them acting on this. Besides the fact that the enzymes can't even act on this because it's lipid soluble. Hope everything is clear so far. I think most of you are going to be watching the recording, so I'm just going to move on. So this makes it possible for pancreatic lipase to work. Now I mentioned pancreatic. Is that the only lipase? Nope, there are multiple lipases. So through your GI tract, starting right here from the mouth, you're going to have a salivary lipase, which is very, very minor. I don't want you to care about it. I'm just telling you that it exists because you're definitely going to hear about it in other lectures. Okay. Then going down to the stomach, you're going to have gastric lipase. Gastric lipase also plays a minor role. Why? Because it only digests medium chain triglycerides. Now, I don't want you to know what triglycerides are for this lecture. It's a topic of a mole lecture, but leave it aside for now. Just know that it only acts on medium chain triglycerides. Why is this a problem? Why is it a minor role? Because most of the food you eat is large chain triglycerides. So you need something that acts on that. So when is gastric lipase important? It's important in infants because their liver isn't really, their pancreas isn't really functioning yet. And it's important with adults with pancreatic insufficiency because obviously their pancreas isn't working. So now you're relying on the gastric lipase. It's a backup. So going to the big boss right here, the pancreatic lipase. Pancreatic lipase plays the major role because it works on all triglycerides. We said that you eat large chain fatty triglycerides. Adi works on it. Medium chain, Adi works on it. Doesn't discriminate. Works on everybody. That's the boss. But the boss kind of has his own special requirements, you could say. It needs bile acids, which we just discussed. It surrounds the lipids and it allows the lipase to work. And it needs something called a co-lipase. Co-lipase is like the pancreatic lipase's assistant. What it does basically is, let's say right here you have this lipase acting on this triglyceride or fat globule, you can say, which is surrounded by the bile acids, which we discussed earlier. It needs this co-lipase to allow it to attach, basically. It kind of anchors in it. So co-lipase helps the lipase attach, and it also creates an optimum pH to allow the lipase to work. So it basically just creates the perfect environment. So pancreatic lipase is the boss. It has its own little environment. It needs its assistant to do these things for it. Attach and optimum pH. Okay, so pancreatic lipase is the main one. Let's keep going. So after the lipases work, they basically work on the fat globule while it's still surrounded by the bile acids. The bile acids don't get affected in the process. So what's going to happen is that these triglycerides, tri for three, get broken down into monoglycerides, mono for one, and fatty acids. These are just breakdown products. I don't want you to get into the details of what these are because it's the topic of a mole lecture. That's not the scope of this lecture or the scope of your GI fund. Okay. Once it gets broken down into fatty acids and monoglycerides, it gets called a micelle. Okay. So what's a micelle? It's basically the transport form. It transports the fatty acids and the monoglycerides to the enterocytes. What are enterocytes? Enterocytes are the cells that line your intestine. So it's basically taking the fats to the place where they get digested and absorbed into your body. Okay. Like, so once it gets there, this is an enterocyte. This is the cell lining your gut. Right? The fatty acids and monoglycerides, since they're fat soluble, they can just diffuse out of the cell with the not the cell of this globule with the bile acids, and it just diffuses straight into the enterocyte. So inside the enterocyte, you're gonna have the fatty acids and monoglycerides. What's gonna happen next? The bile acids are gonna stay in the lumen, as we said, because this diffuses inside, and the bile acids are gonna move on until they reach the ileum. So we were in the duodenum, we moved on to the duodenum. We're at the ileum now. It's just bile acids. They get recycled, like, for future use, for the next fatty acid meal. Okay, but this is 95% of them. Keep this in the back of your mind. What happens next? The fatty acids and the monoglycerides combine to form triglycerides, and then triglycerides combine with proteins to form something called a chylomicron. Chylomicron is similar to a micelle. It's something that just transports the fats outside of the GI tract, you can say, in your blood. Again, there's a whole lecture on this, so I'm not going to go into it. It's not the scope of GI, it's the focus of mold. Okay, so they combine to form triglycerides. They combine with proteins to form chylomicrons to require something called ApoB48. Again, this is really important for mold, but it's not important for GIT. I'm not going to focus on it right now. It is in your slides, but I only kept it here for the sake of completion. Okay, and then chylomicrons basically enter lacteals, which are like lymphatics, and that's just how they get absorbed into your body. Like, that is a rapid, basically, overview of the big idea of how bile acids and fats move through your body. But we're going to go into detail now. Just summarizing, bile salts make fat accessible, lipase digested, micelles delivered to enterocytes, and chylomicrons transported afterwards into your body. Does anyone have any questions so far? Please type in the chat. I can immediately see it, or just interrupt me. Okay, let's go. Which of the following is a function of bile salts? Can someone answer this in the chat? 3, 2, 1. Okay. Bile salts form micelles, we said. This is because you need the micelles in order to digest lipids. Very straightforward. Okay. So let's go deeper into what bile is. Bile, which basically is the liquid which contains bile acids, aka bile salts, same thing. It's made by hepatocytes, which are the cells of the liver, and it's modified by cholangiocytes. This is immediately after. Cholangiocytes are the cells that line the bile duct. So leaving the liver, you have the right and left hepatic ducts, which form the, I think it's called the common hepatic duct, I'm not even sure. Common hepatic duct, which then combines with the cystic duct of the gallbladder, which creates the common bile duct, which then combines with pancreatic duct and drains into water. Whatever, that's anatomy. Cholangiocytes line the bile ducts and they modify the bile. Bile is made by what? By the hepatocytes, which are the cells of the liver. Okay. After it's made by the hepatocytes and it's modified by the cholangiocytes right here, it goes into the gallbladder. Actually, doesn't go straight down. It goes into the gallbladder where it gets stored and concentrated. What does concentrated mean? It basically means that the ratio of bile acids and bile salts to water increases. But there's more, it doesn't create more bile acids and bile salts. It just increases the concentration of it relative to everything else. Once you're done with storing it and preparing it, it gets discharged into the duodenum. What does that mean? It means the gallbladder contracts, and this sphincter right here, called the sphincter of Oddi, opens, and it gets pushed into the duodenum. This happens under the influence of something called cholecystokinin. Cholecystokinin, from the name, cholecyst means gallbladder, and kinin means move. It's the hormone that makes the gallbladder move. Let's keep going. In the duodenum, so once we're here, bile got, what do you call it? What was the word again? Discharged. Once it's discharged into the duodenum, it emulsifies the lipids, which we talked about earlier. Fun fact about it, not really fun fact, an important fact, is that it's isotonic, which basically means isotonic to plasma, which basically means that it's not hyperosmotic or hypoosmotic compared to plasma. It's the same. so it doesn't kind of create any disturbances. But it's alkaline. What does alkaline mean? It has a higher pH. This is important because in the GI tract in general, you have varying pHs. You need the pH in the duodenum to be higher than the pH in the stomach because the stomach has gastric acid, it has a low pH, it's acidic. طيب? So you need something to kind of neutralize it. طيب? Due to bile being alkaline to plasma, it allows it to have this other function, which is neutralizing gastric acid once it gets emptied into the water. Everything good so far? Let's go. طيب. Bile is also an excretory medium for cholesterol. This is basically what we talked about earlier. It allows cholesterol or fats or lipids, whatever, to be digested, and some lipid soluble drugs. It's also antimicrobial. You don't need to know why exactly. You just know it's like a fun fact. Like, and if there's a microbe in the GI tract, bile can kind of protect your body from it. Okay. So where does bile come from? Bile is mostly reabsorbed from the hepatic portal circulation. We talked about this earlier. It's mostly recycled, right? What's the hepatic portal circulation? It's basically this. There's a whole lecture on this. You have basically the arteries go into the GI tract, and then the veins draining from the GI tract, along with the nutrients that were in the food. Right? These veins all drain into the portal vein, which goes into the liver for detoxification and metabolism, right? So the liver both has the portal vein going into it and the hepatic artery. So it has a dual blood supply. I need you to keep this in the back of your mind because it's really important. So the liver has the hepatic artery and the portal vein going into it, and the hepatic veins draining it. The hepatic veins go where? To the inferior vena cava and then to the heart. Right? Bile gets reabsorbed from the GI tract using this. It was just used for a meal. The monoglycerides and the fatty acids from earlier left. Bile gets reabsorbed. From where? From the small intestine into the portal vein, back to the liver, reused once again. طيب. Some is made. Some new bile is made. We said 95% is recycled. 5% is newly synthesized. But how is it made? This is actually a really important part of the lecture. I need you to lock in with me. Okay. Bile synthesis happens in the liver. We already said this. Cholesterol is converted into primary bile acids, which are known as cholic acid and chenodeoxycholic acid. Okay, this is done by the enzyme called 7-alpha hydroxylase. This is a really important enzyme. It's also the rate limiting step. It's the rate limiting enzyme. طيب. What rate limiting is? We take that a moment. It's basically the most important, crucial step. طيب. So cholesterol turned into cholic acid and chenodeoxycholic acid by 7-alpha hydroxylase. Then these primary bile acids are conjugated. We're still in the liver, by the way. They're conjugated with the addition of glycine and taurine, which are amino acids. Right? But you add glycine and taurine, you turn cholic acid to glycocholic acid, and chenodeoxycholic acid to taurochenodeoxy. And these become conjugated bile acids. Conjugated bile acids are more water soluble or ionized. Right? This is important because you need them to be. You need them to be able to flow properly. You don't want them to be lipid soluble. Right? So we took cholesterol, we made it into primary bile acids, 7-alpha hydroxylase. Then we turned the primary bile acids into conjugated bile acids by adding glycine and taurine, and now they're more water soluble. Still in the liver. Right? This conjugation allows it to be amphoteric, which means it has a hydrophobic side and a hydrophilic side. Amphoteric literally means it can both act as a base and as a acid. Okay? So it's amphoteric. I think the acidic side is hydrophilic. The basic part is hydrophobic. It doesn't really matter so much. I just know that because you conjugated it and you made it water soluble, then it can kind of have the property that you want it to have, the actual function that it has, which is being amphoteric. Okay? So once you leave the liver, you're going to go into something called the bile canaliculi. Between the hepatocytes, you have something called the bile canaliculi, which then goes into the bile ducts, which leaves the liver. But now we're there. We're in the canaliculi and the bile duct. The conjugated bile acids get modified by the cholangiocytes. We already talked about this. What do the cholangiocytes do exactly? And just keep in mind, cholangiocytes are the cells that line the bile duct. These cholangiocytes have a CFTR channel. This CFTR channel adds chloride. It adds chloride in here. It adds it into the bile. Okay. This chloride, once it goes in, it gets exchanged for bicarbonate. So it goes back inside chloride goes in, goes back inside, and a bicarbonate goes out. Bicarbonate is alkaline, so thus you're making the bile more alkaline. Bicarbonate also attracts water, so thus you're going to have water added and bicarbonate added. So this is going to make the bile more dilute, which means it's less concentrated, and more alkaline, which means it has a higher pH. Okay? Okay. CFTR, the channel that added the chloride and thus made it more dilute and alkaline, is induced by a hormone called secretin, which you might have heard of in your other GI physiology lectures. Like, when does secretin do this? When we eat, when you have a meal, and does this through a cyclic AMP mediated process. Why does secretin do this? It does this to neutralize gastric acid. You just had a meal, gastric acid is about to go into the duodenum. You need to make sure the bile is alkaline enough in order to neutralize the gastric acid, which is going to go into the duodenum, because you don't want to have an ulcer or anything, right? Right. Sorry. Now we left the bile duct and we're in the gallbladder. We left the liver, we left the bile duct, we're in the gallbladder. Once you're in the gallbladder, hydrogen moves in, and so does bicarbonate. But bicarbonate, we said, made it more alkaline earlier in the bile duct. Now bicarbonate also still moves in, but so does hydrogen. And hydrogen ions basically are acidic. You know, bicarbonate is more alkaline. With these two moving in at the same time, you think there's nothing happening. But because hydrogen moves in more rapidly, it actually makes the bile more acidic now. So it became more alkaline in the bile duct and then more acidic in the gallbladder. Now you might be thinking, Abdullah, didn't you just tell us that we're trying to neutralize gastric acid? Why are we making it acidic? You're making it more acidic, but you're not making it borderline acidic. Okay, it's still going to have its function that you need, which is being able to neutralize gastric acid. Okay, so don't get confused there. So why does hydrogen move in more rapidly than bicarbonate? Because there are more sodium hydrogen exchanges than chloride bicarbonate exchanges. I just understand this. You don't need to really memorize it. Just have an idea that there are both of these channels, that there are sodium hydrogen exchangers, which are adding hydrogen, and there are chloride bicarbonate exchangers, which are adding bicarbonate, but there's more of the sodium hydrogen exchanges. Therefore, there's more hydrogen going in. Right. What's the net effect? pH decreases. Why is this important? It prevents the precipitation of calcium. What does precipitation of calcium mean? When something precipitates in solution, it forms its own little thing at the top, right? Remember that from high school chemistry, right? If calcium precipitates, you get a gallstone. You get a stone. You get a stone in the gallbladder. Right? You don't want that to happen. So while you're in the gallbladder, you don't want the pH to be too high. You don't want it to be too alkaline, because that's kind of the environment where calcium precipitates and forms a gallstone. But that's why you need it to become acidic. So, quick recap. I'm moving really quick. The liver creates the bile, and then it leaves. It gets conjugated, and then it leaves water-soluble amphoteric into the bile duct, where it gets modified, made more alkaline and more dilute, and then it goes into the gallbladder, becomes more acidic. Right? Why did it become more acidic in the gallbladder? Because you don't want calcium to precipitate. Why did it become more alkaline in the bile duct? Because you wanted to be able to neutralize. Why did it become more alkaline? Yeah, because you wanted to be able to neutralize gastric acid. Right? So the result is that bile is more concentrated and acidic. So you actually also have a reduction of water, basically. Water actually leaves a little bit, but the bile gets more concentrated, and since there's hydrogen added, you get more acidic a little bit. So in the bile duct, it's more diluted and alkaline, and in the gallbladder, it's more acidic and concentrated. Okay? Okay. Now, when the gallbladder finally contracts, CCK acts, it gets released in the intestines. Now it's actually doing its job. Once it's done with its job, once it does what you need it to do, intestinal bacteria deconjugated. Remember when we conjugated it 10 years ago? It deconjugates and it dehydroxylates it, which turns it into a secondary bile acid, which is deoxycholic acid and lithocholic acid. These are more fat soluble, which is not what we want, but it's okay because it already did its function. We're about to recycle it anyways, okay? Important fact about these, lithocholic acid and deoxycholic acid is that lithocholic acid is not reabsorbed. We said we're recycling here, right? Lithocholic acid is not reabsorbed because it's toxic. It's excreted normally, right? Deoxycholic acid is 95% reabsorbed. Okay? Okay, so this is the one that you take back. Check one. Someone typed in the chat. I thought the small intestine was sterile. Yes, it is sterile, but it has something called normal microflora. So it has bacteria which live there normally, and they're not bad for you. طيب? يعني obviously you can have bacteria there which is bad for you, but there's always bacteria in your GI tract, all over your body, حتى on your skin, whatever, which is called normal microbiota or normal microflora. It's the same thing. طيب? So these bacteria are actually good for you. You need them to do this. Okay? All good? Okay. So small intestine, large intestine have their own bacteria. Yes, there's bacteria living in your small intestine 24/7. It has its job. It's doing what it needs to do. It doesn't hurt you. It actually helps you. Okay. You're welcome, man. Thank you. Okay, so can you answer this question, man? While we're at it, which of the following is a characteristic of primary bile acids? A, does it get converted into secondary bile acids in the distal ileum? You wanna read it? Okay, I think someone opened their mic back. So. Does it get converted to secondary bile acids? Is it deconjugated in the liver? Is it completely lost in feces? Or is it formed through? They went to glycine and taurine. True, but I think primary bile acids are the ones which are already bound to glycine and taurine. But what happens to them now? They get converted to secondary bile acids. Primary bile acids get converted to secondary bile acids. The only way they can mix you up here is basically telling you the wrong place where it happens. They're telling you they can convert to secondary bile acids in the distal ileum. It's okay. The cecum and the colon, which is where the bacteria acts on it. Okay. Do they get deconjugated in the liver? No. We said the bacteria does that in the small intestines. Are they completely lost in feces? No. We said that they're actually mostly reabsorbed. Is it formed through deconjugation by bacteria? No. Primary bile acids are the conjugated bile acids, which just left the liver. All good? All good. Which of the following bile acids most likely appears in the stool normally? So we just talked about this. Which of the following is normally excreted? You don't want it. It's toxic. It's bad for you. D. صح عليكم. Nice. We said lithocholic acid is toxic. Okay. Okay, it's a long question. What is the difference between bile secreted from the liver and bile stored in the gallbladder? I'll give you guys a second. A. The bile in the liver contains more bicarbonate and fewer bile salts than the bile in the gallbladder. صح. That's 100% right. We said in the gallbladder, just remember one of them. If you don't have to remember what happens in both places to answer this type of question. In the gallbladder, it becomes more concentrated and more acidic. So obviously, the bile in the liver is going to contain more bicarbonate, which is the opposite of acidic. It's more alkaline, and it's going to have fewer bile salts. Technically, not fewer bile salts by quantity. It's just less concentrated. It's more dilute. That's what they're trying to describe here. The rest of the options are pretty much the same wording, but just differently. They're just wrong. They just have different, fewer, less, whatever, right? But all these questions I have here are past questions, the actual questions that came in the exam. They're straight out of the past booklet, okay? Okay. So how does bile get recycled through the liver? So we said that bile gets reabsorbed. How does it do that? Okay. This is a cross-section histology of the liver. This is a lobule. You might be thinking, Kharsa, why do you have the histology in front of me? Don't worry about it. Okay. This is a lobule in the liver. In the corners of this lobule, of this hexagon, or whatever the shape is called, you have something called a portal triad. This portal triad has three things: branch of a portal vein, branch of a hepatic artery, and branch of the bile duct. Remember when a couple slides ago, I told you that the liver has dual blood supply, which means it has both the portal vein coming from the GI and the hepatic artery coming from wherever it's coming. They're both supplying the liver. They both have branches that are in the portal triad. The third thing in the portal triad is the branch of a bile duct. The portal vein and the hepatic artery are coming to the liver, and the bile duct is leaving. But you have two things going this way and one leaving. Where are they going? They're going to the central vein. Where does the central vein take you? It takes you to the inferior vena cava, which takes you to the right atrium, right? Right. But you have the hepatic artery and the portal vein flowing this way. Let me show you in this picture. You have the hepatic artery and the portal vein flowing this way, and the bile duct flowing the opposite direction. The hepatic artery and the portal vein don't flow separately. they actually combine right here to form something called a sinusoid. Okay, I'm showing you the same thing, by the way, in just different what do you call it, perspectives. This is the hepatic artery coming here, the supportal vein coming here. They combine to form the sinusoid, which drains into the central vein, which goes to the IVC, which goes to the heart. These are hepatocytes, cells of the liver, right? And this is the bile duct, which drains the bile. طيب? طيب. This is just another perspective. Same thing again. Hepatic artery, portal vein, all going to central vein. The bile duct is draining and going away from the liver. Like, I'm going to need you to note something. This hepatic artery, does it have deoxygenated blood or oxygenated blood? Obviously, oxygenated blood. It's an artery, right? It's not one of the exceptions. So it mixes with the portal vein, which has the nutrients from the GI and whatever. And then this sinusoid is going to have oxygenated blood. The blood is going to be oxygenated and it's going to be feeding these hepatocytes. As it moves this way, it's going to lose the oxygen. Right? But as you move closer to the central vein, oxygen is lost. And therefore, there's less oxygen being provided to the area closer to the central vein, making it more sensitive to ischemia. Ischemia is basically lack of oxygen or lack of blood flow to an area, thus damaging it, basically. Right? But if you look at it, scientists basically divided this into zones. You have zone 1, which is closer to the portal triad, closer to the hepatic artery, portal vein, bile duct, so on, and that's where the bile is uptaken. We're going to talk about that in a second. You have over here zone 3, don't worry about zone 2, zone 3 right here is centrilobular, which means it's more closer to the center of the lobule, which is where the central vein is. Right? In this area, you have less oxygen, but the metabolic processes going on there are going to be less reliant on oxygen. So anaerobic glycolysis, there's going to be drug detoxification. Don't ask me where that happens, just know it. And it's going to be sensitive to ischemia. Any questions so far? Because I'm kind of moving quickly because I'm mostly relying on people watching the recording. Salah. Any questions? Yeah, Zaid and Batul? Nope, thank you. Okay, I'm glad everything is clear. But in this, you might have noticed there's a bunch of cells, stellate cells, Kupffer cells, so on. We're going to talk about them now. The Kupffer cells are just macrophages. You know what macrophages are. Macrophages are the immune cells which phagocytose things in your body, and they just have different things when they go to different places. Don't ask me why they like to do identity theft. They just like doing it. They're named Kupffer cells in the liver. And they line the lumen of the sinusoid. So we said the sinusoid is formed by the portal vein and the hepatic artery. They line the lumen. They're inside. The lumen is what's inside. Besides the Kupffer cells, you have these things called stellate cells. If you notice, they're outside the sinusoid. Between the sinusoid and the hepatocytes, you have something called the space of Dicey right here. The space between the sinusoid and the hepatocytes is called the space of Dicey. So that's where the stellate cells are. What do? They store vitamin A. Don't ask me why. Just memorize it. It's really important. And they secrete collagen in liver damage. What does that mean? If someone, I have a question. Is the space of this the same as perisinusoidal space? I've never heard perisinusoidal. I can check that for you. One second. It would make sense. Peri means around the sinusoid. So let me see. Just so ما هبت من عندي يعني تطلع غلط. Is the space of this the same as perisinusoidal space? Yes, it is. Okay, according to AI. But yeah, the stellate cells are in the space of Dicey or the perisinusoidal space, and they do two things. They store vitamin A and they secrete collagen when the liver is damaged. But let's say someone is a chronic alcohol abuser and the liver is damaged. They have something called liver fibrosis. You might have heard of it before. Who's the culprit behind liver fibrosis? It's the stellate cells because they're secreting collagen, thus fibrosing the liver. Now we're going to talk about how bile is secreted from the sinusoid. We said bile is coming from the GI tract. It's going to recycle. It's coming from the portal vein. It's going to recycle. It's going to the sinusoid. How is it going from the sinusoid into the hepatocytes? That's what we're going to talk about next. This is a hepatocyte. This is a hepatocyte literally taken from right here. Between each hepatocyte, you have something called a bile canaliculi or canaliculus, right? So this is the hepatocyte, and it has the bile canaliculus, right? From your GI tract, you're gonna get some conjugated bile acids, and you're gonna get some deconjugated bile acids, طيب, depending if the bacteria managed to deconjugate it or not. Both of them are picked up عادي. طيب. They go in different places. I'm gonna give you a way which helps you remember how they go in. طيب. So I'm gonna need you to live with me for a second. Imagine conjugated bile acids as strong bile acids and deconjugated as weak. طيب. When you're strong and okay, when you're strong, you're going to be eating things that make you stronger, which are protein, right? But the conjugated bile acids go in with the NTCP, or as I like to call it, the nugget teriyaki chicken protein. Just remember chicken protein, or nugget teriyaki chicken protein. This is literally nuggets with teriyaki sauce, their chicken and their protein. طيب. The conjugated bile acids, strong bile acids, go in with the nugget teriyaki chicken protein. The deconjugated bile acids, the weak ones, they're on a diet. Like they're trying to lose weight. Again, nothing against people who eat oatmeal, but if you're eating oatmeal, you're probably trying to lose weight. But the deconjugated bile acids go in with the oatmeal protein. طيب. The nugget teriyaki chicken protein is a secondary active transporter, which means that it uses the sodium gradient to go in. That means there's a sodium potassium pump somewhere else, and it's pumping out sodium and creating a sodium gradient, and then the conjugated bile acid goes in with the sodium at the same time. Like, what happens next? Well, this is the oatmeal process. What happens next? The deconjugated bile acids, once they're in, they get conjugated. Like, they hit the gym. They all get strong. Like, once you're strong, once everybody inside is strong, they have biceps, but they go in with the BSEP or the bicep. When you're strong, you're using energy by using ATP. طيب, so they go in with the bicep or the BSEP and they use ATP. Where do they go? They go into the bile canaliculi. Remember the bile canaliculi من هون? طيب, which drains into bile duct? They go into that. طيب. Well, this is the biceps right here. Okay. But the BSEP is the rate limiting step. Now, when Dr. AJR was explaining, he said this is the second rate limiting step. What he meant is that this is the second rate limiting step we have talked about today. The first one, if you remember correctly, was 7-alpha hydroxylase, which was the rate limiting step of the synthesis of bile acids. BSEP or bicep is the rate limiting step in the secretion of bile into the canaliculi. But they're both rate limiting steps, but they're different processes. Right? Don't think that there's a first and second rate limiting step. I don't know if that ever happens in reaction, Salaha, but this is the rate limiting step of bile secretion into canaliculi, and 7-alpha hydroxylase is the rate limiting step of biosynthesis. طيب. All clear so far? Any questions? Just type in the chat at any time. Yeah, Zaid and Batul. Nope. I'm glad. Thanks. طيب. So we're inside the canaliculi now. What happens? Bile salts, they pull water inside. Why? Because of osmotic gradient. You've took this in FND. They're salts, but they pull water. Water goes in. Right? What else goes in? A bunch of random stuff that's not really important, صراحة. Cholesterol, phospholipids, glutathione, bicarbonate. Doctor mostly stressed on glutathione because it has a clinical relevance, but Dr. AGR he didn't really stress on it, and I don't see how they can ask it. But if you want to memorize it, you can memorize it. I just put it here for the sake of completion. I have a question. Can you guys answer this question? The reabsorption of bile salts from portal blood into hepatocytes is completed by which of the following mechanisms? Focus on completed. Focus on the last thing we did. Come on, guys. Adi, just throw an answer. Whatever you feel like is right. You don't know? Completely fine. Let's go back. The reabsorption of bile salts from the portal blood into the hepatocytes is completed by which of the following? Let's look at the choices. Facilitated diffusion. Facilitated diffusion, I think it's where they diffuse in with a channel, but they don't use energy, because it's diffusion. An active carrier-mediated process. Active means it's uses energy. It's done with a carrier. Looks correct to me, Salaha. Which is basically what they're talking about. The NTCP or the negative chicken protein, and the oatmeal protein. طيب, mainly the NTCP طيب, is the one that uses energy. It has a secondary active transport method. طيب. Conjugation with chloride never gets conjugated with chloride. Is it transformed secondary to primary? No, that doesn't happen. Do you get it? Do you get what channel we were talking about? Is it B because it's exactly? Is it B because from? Thank you. That's completely correct. Do you get it, yeah, Batul? Okay, I'm glad. Fine. Answer is B. Let's go back to this. Once you're inside, the bile acids and the phospholipids and the glutathione and the water والشباب كلهم they're inside. طيب. Once they reach something called the critical micelle concentration, I think it's active too. Is oatmeal secondary active transport or what? صراحة the doctor didn't mention it. The one that was mentioned is that it's secondary. The NTCP is secondary active transport. So whether it is or not, he's not going to ask about it. If you want to know it, it's fine. صراحة. But I don't really see it being mentioned anywhere. طيب. So once they're inside, when they're above something called the critical micelle concentration, they form micelles. Remember micelles from like 10 years ago? The transport form? We have it again. طيب. The bile acids, they form micelles. They don't have the fats yet, but they're like the soldiers. They're on a mission to leave right now. طيب. What's the critical micelle concentration? Critical micelle concentration is a ratio. It's a ratio between bile salts and phospholipids and cholesterol. You know how we said that phospholipids and cholesterol get added? You have a certain balance between bile salts, phospholipids, and cholesterol. But it's like the safe ratio. Why is it the safe ratio? Because if you're not in the critical micelle concentration, cholesterol will precipitate. Can someone guess what happens if cholesterol precipitates? Just type in the chat. Yalla, guys. What happens if cholesterol precipitates? Stenosis. Pretty much, stenosis is wide, what do you call it, narrowing, which happens due to, thank you, Batul, stones. Stones form from cholesterol because it precipitated, because you're not in the concentration where it's a micelle. Okay, outside of the critical micelle concentration, it precipitates. You get a stone, which can block the bile duct. Right? But you get gallstones. How do they present? Nausea, right upper quadrant pain, steatorrhea. Steatorrhea is basically where you're not getting your bile into the intestines. So due to that, you're not able to digest lipids. But when you're not digesting lipids and fats and so on, you're excreting them as they are. You're excreting them as lipids. But the feces ends up being whiter or pale colored. They call that steatorrhea. طيب? All of these symptoms are aggravated after lipid-rich meals. If you eat lipids, you get cholecystokinin, the gallbladder contracts, you get more pain, more nausea, more steatorrhea. Right? This is what a gallstone looks like. This is inside the gallbladder. It's pretty ugly, صراحة. Yeah. So if everything is clear, we're going to talk about what a gallstone does at different levels. Let's say a gallstone formed. Let's say you're out of the critical micelle concentration and you got a gallstone. Where it gets stuck has different symptoms. And this is really, really important. There's a high chance of this coming in the exam. Right? Let's say the gallstone. Well, actually, let's review the anatomy first. We said you have the left and right hepatic ducts coming from the left and right lobes of the liver. They form the common hepatic duct. From the gallbladder, you have the cystic duct. The cystic duct and the common hepatic duct combine to form the common bile duct, which combines with the pancreatic duct, which has the pancreatic lipases and the enzymes, to form the final duct, which empties into the second part of the duodenum at the ampulla of water, which has a sphincter of Oddi. If a gallstone gets stuck at the cystic duct, which is the duct of the gallbladder, the bile is going to be perfectly delivered. It's going to leave the liver. It's going to go straight to the intestines when it's needed. The sphincter opens, you go. It's not going to be perfect. It's not going to be the perfect modified bile that you need usually, but it's going to get there. But because the gallbladder has a stone in it, it's going to be inflamed. So you're going to get something called cholecystitis. Cholecyst means gallbladder. Whenever you see cholecyst, choly literally means gall or gallbladder. Cyst means bag, gallbladder. Cystitis is inflammation. But the gallbladder is going to be inflamed. If the stone gets stuck at the common bile duct, you're both blocking the gallbladder and the left and right hepatic ducts of the liver. So now, is bile getting to the intestines? No, you're decreasing the bile salts. But the bile isn't going to get to the intestines to help you out with this function. The pancreas is not blocked. It's perfectly fine. The pancreatic enzymes still leave. But what are you going to get? You're going to get steatorrhea. Remember steatorrhea from earlier? The intestines aren't getting the biles, but you're not digesting the lipids, but you get steatorrhea. You are still going to get cholecystitis because the gallbladder is kind of blocked, but there's inflammation going on, right? And you get something called obstructive jaundice. Obstructive jaundice is going to be the topic of the second lecture we're covering, but we're going to talk about it later in the video, but just keep it at the back of your mind right now. Right? Now, if the stone gets stuck at the sphincter of Oddi, which both blocks the liver and the gallbladder and the pancreas, you're going to get decreased bile salts. You're going to get blocked pancreatic enzymes. You're going to get cholecystitis والشباب كلهم خلاص يعني because you're blocking the liver, decreased bile salts. You're blocking the pancreas, you're going to get blocked pancreatic enzymes. You're blocking the gallbladder, you're going to get cholecystitis. What happens because you're also blocking the pancreas now and the pancreatic enzymes are staying inside? The pancreatic enzymes ما حيصبوا. They're going to digest the pancreas. And that's called pancreatitis, inflammation of the pancreas. And you're still going to have the other symptoms from earlier, steatorrhea, cholecystitis, obstructive jaundice. But just notice how these are kind of in a sequential order where you just get one extra symptom every time. And I want you to understand it, not memorize it. Because if you understand it, you won't have a problem. Does cholecystitis cause right upper quadrant pain after fatty meal, or does the gallbladder not contract? It does contract, and that's why it hurts extra, you know? Like cholecystitis will have right upper quadrant pain all the time. But after the fatty meal, because you have cholecystokinin, the gallbladder contracts, and it just hurts even more. But that's why it's aggravated. Okay, thank you. Right. Checkpoint. Which of the following would most likely lead to the formation of cholesterol stones? By the way, all of these are past questions, as I mentioned. But this is talking about what? The critical micelle concentration. Critical micelle concentration, let's just look at it really quickly. 10 bile salts, 3 phospholipids, and 1 cholesterol. So you're going to have a lot of bile salts, a little bit less phospholipids, and very little cholesterol. طيب? So what's going to happen? C, high cholesterol levels and low phospholipid and bile salt concentrations. That's 100% correct. Because if you, let's go through the options one by one. I would say, mashallah alaikum, wallah, you guys are doing amazing. The options one by one. A is high bile salt concentration and low phospholipids. No, that's what you need. Low cholesterol, high phospholipid, and bile salts. And even if you have high phospholipid, you also need the high cholesterol. Cholesterol is sort of the main risk factor, you can say, for gallstone. High cholesterol levels and low phospholipid and bile salt, exactly. High bilirubin, we're going to talk about that بعدين with the obstructive jaundice. طيب. Another question. A 45-year-old woman presents with upper abdominal pain and nausea after fatty meals. She's diagnosed with gallstones. Which of the following is most likely the cause? It's pretty much the same question once again. But these are both past questions. I'm just putting it in here to show you how high yield this is. A, exactly. High cholesterol levels, low bicarbonate, and low phospholipid. So this came in the past twice, really. And I just want to note something. This is from another lecture, but 45-year-old woman, these are kind of the risk factors for gallstones. I think it's like 4 Fs, 40 female, fat or fair. Fair is like light skin, fat is overweight, 40 years old, female. This is basically the most common demographic which has gallstones, basically. So when you see them describing this, يعني حتى without them telling you diagnosed with gallstones, you should know what it is. طيب. We're reviewing here really quickly. The bile leaves the liver in the common hepatic duct, goes to the bile, so on, and you have this whole circulation. طيب. They have this whole system moving. طيب. There are 2 ways you keep this moving. طيب. There's 2 ways you keep this whole system moving. One is bile dependent and one is bile independent. The bile dependent flow is where you have more bile acids, therefore pulling more water, therefore more flow. طيب. يعني I have a question. Okay. طيب. You have more bile acids, which pull more water because they're also salts. They're bile acids, aka bile salts. They pull more water, so you have more flow. And the bile independent one, it happens through the hormone secretin. Remember secretin from earlier, which added the bicarbonate to the bile. But the secretin acts at the bile duct. It adds more bicarbonate. Bicarbonate also pulls more water and causes more flow. That's it. This is very يعني صراحة حسيت low yield بس it's in the slides ف يعني you should know it. طيب طيب we're almost done with the first lecture. Bile reabsorption from the ileum. But now the fatty acids and the monoglycerides left the micelle. You have the bile acids moving on. They reach the ileum. The bile was discharged in the water. You have the digestion in the jejunum, and then in the ileum, you're about to reabsorb the bile. So how does it happen? The channels that happen. For conjugated bile acids, they're absorbed with a channel called the ASBT, along with sodium, kind of similar to the nugget teriyaki chicken protein. طيب. And then the second channel that passes through is the OST. طيب. صراحة I couldn't think of a mnemonic for this one. They do kind of look like the nugget teriyaki chicken protein and the oatmeal, but the only difference is that the OST is the conjugate. That doesn't really work here. طيب. The unconjugated bile acids, they're fat soluble, so they just diffuse right through. They don't need a channel. طيب. Because that's how lipid soluble molecules act when they're being transported. طيب. طيب. Are we clear so far? Is everything good? Let's keep going. Yes, okay, I'm glad. So how is this whole process regulated? طيب. There's going to be two ways you're regulating this. The enzyme that's synthesizing, by the way, just note how these are the two rate limiting enzymes. Remember, we said 7-alpha hydroxylase is the rate limiting enzyme for synthesis, and BSEP or BISEP is the rate limiting for secretion. But obviously, they're going to be the ones you're regulating in order to regulate the whole process. But if you have high levels of bile acids in the hepatocytes, but the hepatocytes are the ones who sense this, you have high levels of this, you're going to be inhibiting the synthesis enzymes and you're going to be increasing the secretion. But the hepatocytes are like, okay, we have too many bile acids, we're going to synthesize less of them and we're going to secrete more. طيب. If it's the opposite, if you have low levels of bile acid in the hepatocytes, you're going to be inducing the enzyme, which is 7-alpha hydroxylase. You're going to be synthesizing more bile acids. You have little. And you're going to be secreting less through bicep. طيب. Is this clear? I want you to understand this, not memorize it. I'm trying to explain it. Everything good? خلاص. How does bile get pushed out of the gallbladder? Question clear. Okay. We said cholecystokinin, the enzyme that makes the gallbladder move. Cholecyst means gallbladder. Kinin, move. طيب. It acts through two ways. طيب. This is really important, by the way. Okay? The first way is kind of minor. Cholecystokinin is a hormone. It literally acts how it's supposed to be. It goes from the blood, travels all the way to the gallbladder, gets to the gallbladder. لو سمحت, can you contract? The gallbladder is like, okay. Takes forever. It's a minor way. The major way, the main way that cholecystokinin causes the gallbladder to contract and the bile to be emptied is the vagovagal reflex. Why is it called the vagovagal reflex? Because cholecystokinin stimulates the vagus nerve, which you might have heard of in CVP. It's the most parasympathetic, biggest parasympathetic nerve. طيب? But the vagus nerve senses the cholecystokinin or gets stimulated by the cholecystokinin, and it sends another vagus nerve to do two things. One of them is release acetylcholine at the gallbladder, which causes it to contract. And the other one is releasing nitric oxide and VIP, which opens the sphincter of Oddi, thus letting you go through the ampulla of water into the second part of the duodenum, allowing bile to get pushed out of the gallbladder. طيب? Is this clear? يلا. Bile secretion is facilitated by CCK of cholecystokinin through which of the following mechanisms? يلا اسرع 5 4 3 2 1 يلا answer. A ممتاز يا اخي والله انكم اساطير. طيب vago perfect. We're done with the first lecture. The first lecture is the much harder one. The second lecture is much easier, but we're gonna get this done really quickly inshallah. طيب. I'm glad you guys are on track to me. طيب. Bilirubin. What is bilirubin? Let's say you have a red blood cell. The red blood cell gets old, the red blood cell is about to die, it gets phagocytosed by a macrophage. طيب. Red blood cells have heme. Heme is metabolized by an enzyme called heme oxygenase into something called biliverdin, which is green colored. But I think it took this in FND, but يعني consider it. Biliverdin. Biliverdin is then reduced to bilirubin, which is yellow. يعني it says yellow brown, but it's kind of more on the yellow side. طيب. فthis bilirubin, which is unconjugated by now, kind of similar to how we have conjugated and unconjugated bile acids, we have unconjugated and conjugated bilirubin. Wow. طيب. This unconjugated bilirubin in the macrophage leaves and travels with albumin because it's toxic. You don't want unconjugated bilirubin moving around your body. Albumin escorts it to the liver. Why do you take it to the liver? To conjugate it with what? With UDP, glucuronyl transferase. What does this long enzyme do? It conjugates it with glucuronic acid. Okay, thank you guys, thank you. طيب, it gets conjugated with glucuronic acid. Why do you conjugate it? Similar to bile acids, you're making it water soluble. Conjugated bilirubin is known as direct bilirubin, which is dissolvable in water. Unconjugated is indirect bilirubin, which is unconjugated. Why are they called direct and indirect? It's something to do with how they measure it. I don't want you to care about it. Just memorize. Direct bilirubin is conjugated. It's water soluble. Why is it conjugated? By glucuronic acid. Why? As we were in the liver. Unconjugated bilirubin is before the liver. It's before it got to the liver. It's known as indirect. It's water insoluble. It needs to get escorted by albumin. All good? All good. Fine. After it gets conjugated in the liver, the bilirubin goes through the bile duct. But now you might be seeing where this is going, how this is tying into the first lecture. Conjugated bilirubin goes through the bile duct into the sphincter of Oddi and gets excreted into the gut. In the gut, it becomes urobilinogen thanks to gut bacteria. طيب? Similar to how the primary bile acids became secondary bile acids by the gut bacteria. It becomes urobilinogen. Urobilinogen has two paths. Most of it, but I don't want you to memorize these numbers because these numbers are different from textbook to textbook. They're different from slide to slide. None of these percentages are ever completely true. It's just in the majority. Right? 80% of urobilinogen is excreted in the feces as something called stercobilin. Why does it become stercobilin? Because it gets oxidized. It gets some oxygen, gets oxidized, and becomes stercobilin, which is brown, which gives the brown color of stool. The little bit of it does not get excreted in stool. Instead, it goes up back into the body. Most of it goes back to the liver and gets recycled once again. A little bit of it, 20% of this, 10% of that goes into the kidney to get excreted in the urine as something called urobilin, which is yellow, which gives the urine its yellow color. Everything good? Inshallah. So, I just spoiled it. I just spoiled everything for you. We said you have unconjugated bilirubin here, conjugated bilirubin there, it goes to the bile duct. Remember when we talked earlier about gallstones? Stones in the bile duct, stones in the gallbladder. What if you block the bilirubin? What if you block the bilirubin and you can't excrete it? You're going to have buildup of bilirubin in your body, which is yellow. Remember how we said it's yellow? Where does it say that? Bilirubin yellow. But you get something called jaundice, where your eyes are yellow, your skin is yellow, and so on. This does not just happen due to obstruction. This can also happen if you have too many red blood cells being broken down. Why? If you have too many red blood cells being broken down, too much heme is in your body, too much heme is being turned into bilirubin, but too much bilirubin for your liver to keep up with. I think because it's soluble. Why is this? Why is some urobilinogen reabsorbed into the liver? I'm not sure, Salah. I think just some of it goes into the feces and some of it goes back to the liver. يعني at the end of the day, you're not going to excrete everything because it's soluble. Well, if the doctor said it, then then it's definitely true. Dr. HR definitely knows what he's talking about. طيب. So we said either you have too many red blood cells being broken down, giving you too much bilirubin, which is not conjugated yet because it hasn't gone to the liver, but you're blocking kind of over here. طيب. Again, you're going to have a buildup of bilirubin, you're going to have jaundice. If you're blocking the bile duct or anything around here, طيب, you're gonna have a buildup of conjugated bilirubin, you're still gonna have jaundice. طيب. فjaundice, it's abnormal yellowing of the skin and or the sclera. This is the sclera. طيب, due to bilirubin deposition or hyperbilirubinemia. Hyper, too much bilirubin, emia in the blood. Secondary to either increased production, so too much red blood cells are being broken down, or decreased clearance, so you're not able to get rid of it. طيب? So, which is either impaired hepatic uptake or conjugation or excretion. So you could even have a problem with conjugating it. You could have a problem with conjugating it, and you're not going to be able to excrete it. You could have a problem with getting it out of the liver, and you're not going to be able to excrete it. You could have too much red blood cells broken down, and the liver is not going to keep up. Like this is just a mnemonic to remember: hot liver, hemolysis, obstruction. Hemolysis, basically too much destruction of red blood cells. Obstruction, as we said, tumor. I guess tumor can obstruct, and liver disease, because the liver is doing what? It's conjugated. If the liver is diseased, you're not conjugating. You're having too much unconjugated bilirubin to excrete. Like over 60% of newborns have jaundice when they're born. Right? Why? Because the hepatocytes are still immature. Their hepatocytes can't conjugate the bilirubin yet, but they're having buildup of bilirubin. This is completely normal. It's physiologic. طيب. Think they like put a light on them or something, and the baby's fine in like 2 days. طيب. طيب. So we said you can have a blockage here, you can have a blockage here, you can have a blockage there. This is what we talked about. The direct. Okay, actually, we didn't really go into it properly. Like, if you have a blockage here, before you go into the liver, you have a buildup of unconjugated bilirubin, but you get indirect hyperbilirubinemia. If the blockage is here, you have a buildup of conjugated, which is direct hyperbilirubinemia. Can you have both? Yes, you can have both. Mixed hyperbilirubinemia. Can you have a problem with conjugation? Yes, you can. Now we're about to go into this one by one. Conjugated or direct bilirubin, it's either obstruction, gallstones, cholangiocarcinoma, it's cancer of the bile duct. Don't care about that صراحة. طيب, liver cancer, primary sclerosing cholangitis. This is mentioned in your slides for some reason, man. It's way too advanced. Just so you understand it properly, sclerosing basically means thickening. Sclerosing of the of the bile duct, thickening of the bile duct, you kind of see where it's going. This is blocking the flow. طيب. Tumors, just mentioned here. Parasites, again, a literal parasite can be in your bile duct and block it. طيب. You could also have a defect with excretion, like Dubin-Johnson or Rotor syndrome. The doctor barely mentioned these. He's never asked about them before, but for the sake of completion, just know them by name. Unconjugated bilirubinemia can happen due to too much breakdown, because it's still not conjugated, it's before the liver. It's normal in neonates, so it's benign in neonates. It could happen due to something called Crigler-Najjar syndrome. طيب. In Crigler-Najjar syndrome, you have an absent UDP glucurosinyl transferase. Remember this enzyme over here? They don't have the enzyme, but you can't conjugate. It's a hereditary disorder. It's autosomal recessive. From early life, from whenever they're babies, they can't conjugate bilirubin. They can't excrete it. Early in life, they have some neurologic signs. It's very bad. It's pretty rare. Next, you have Gilbert syndrome. Gilbert is like the little brother of Najjar. It's like instead of complete absence of UDP, glucuronyl transferase, you have a mildly decreased. Why? Usually because of stress. Yeah, just kind of happens. ما بعرف صراحة. طيب. Unconjugated bilirubinemia. We just talked about this actually. It can also happen due to spherocytosis. You might have heard of this in FND. It's a hereditary disorder where the red blood cells are shaped like spheres. But due to that, they're being hemolyzed. Hemolysis can also happen due to G6PD deficiency and sickle cell disease. Again, it's just problems with the red blood cells. They're breaking down too much, where you're getting too much indirect bilirubin. Can you get mixed? Yes, you can mixed. It can happen with hepatitis and cirrhosis. طيب? But the doctor didn't really stress on it. So these are the most important. Know the syndromes mainly by name. If I would know one, I would know Crigler-Najjar. طيب? A newborn has jaundice that disappears after a few days. What is the most likely reason? Yalla, guys. Yalla. We're almost done. We're pretty much there. A. ممتاز. Immature hepatocytes. I think this came in the past like at least 20 times. طيب, يعني, it's pretty high yield. Which of the following conditions is a result of the circulation of conjugated bilirubin? I don't know why this is 65. A. Neonatal jaundice. B. Sickle cell. C. GCD. D. gallstone. فconjugated bilirubin فthis is direct bilirubinemia اللي هو طيب hyperbilirubinemia. فthis is going to be after the liver. It's not going to be before the liver. Can we get some answers? يلا guys يلا. B. ممتاز gallstones. Neonatal jaundice, they can't conjugate طيب because the hepatocytes are immature. Sickle cell anemia, it's before the liver also because the red blood cells are sickle shaped, for they're being broken down, they're dying, they're causing too much heme to leak. G6PD, same thing. طيب these are all these are hemolysis, and this is a problem with conjugation. The three of these lead to indirect bilirubin hemato اللي هو يا أخي, you know what I'm talking about. Gallstones lead to blockage, leading to direct hyperbilirubinemia or conjugated. B and C are both hemolytic, which is indirect. Yeah, exactly. طيب. Last concept. I think this is the last concept at least. طيب. Panadol or acetaminophen or painkillers, whatever, paracetamol طيب, they can damage your liver. Why? Because once they go in, they form this thing called APAP. But I don't want you to pay attention to the details of this diagram. It's for explanation purposes. APAP gets then metabolized to NAPQI. NAPQI is a free radical. You know what free radicals are by now, probably. They can cause damage to wherever they are. They're horrible. طيب. NAPQI is usually cleared, you get rid of it by glutathione. Okay? It's usually, you get rid of it by glutathione. طيب. If you have too many acetaminophen and NAPQI, then you can't keep up with it, then it's going to damage the liver and it's going to lead to hepatocyte necrosis. Now, I'm going to be, mashallah, seriously impressed, and I wouldn't be surprised at the same time if you guys answer this. In which zone of the liver is this hepatocyte necrosis going to happen? Can someone tell me? In which zone of the liver is the damage of the free radical mostly going to happen? يلا guys. Damn. That's okay. That's all right. Okay. It's going to happen in zone 3. Remember zone 3 from like a million years ago? Yes, 3. I'm guessing you're right. You said it. You're right. Zone 3, which is central lobular. Remember 10 years ago when we said the portal vein, the hepatic artery form a sinusoid and it loses oxygen along the way as it moves towards the central vein, which is in the middle of the lobule. And then that zone around the central vein is called zone 3, which has less oxygen and it's more sensitive to ischemia and damage. There you have it. Acetaminophen, too much of it, NAPQI is going to damage zone 3 of the liver because it's sensitive to ischemia. طيب. And just one more thing, I think it's mentioned in your slides. They give them cysteine to basically, what do you call it? Treat this. They give them cysteine, which gives them glutathione. You're basically replenishing glutathione, right? In order to prevent too much necrosis from happening. This is just another image showing what we talked about. Here we have bilirubin definition. This is the definition of alkaline phosphatase. Alkaline phosphatase is a marker. It's a serum marker which is elevated in cholestasis. Stasis means stop. Chole is talking about the bile or the bile duct or the gallbladder and so on. Right? But anytime you have a gallstone and you have blockage, the cholangiocytes are going to release alkaline phosphatase. How exactly? I don't want you to know it. Right? It's a marker. A lot of stuff like that happens in the body. It's just measured in the body. It increases, and you suspect that you might have a bile duct blockage. Why do you suspect and you're not sure? Because it can happen in other reasons like bone disease. And I think this is the topic of a mole lecture as well. Right? This lecture has a lot of overlap with mole, but I tried to stay in the GIT lane as much as possible. And this is a summary of most of GIT physiology from first aid. They're just tables. I'm not saying rely on this. I'm saying this is a rapid review. Just screenshot the slide or take it from the slide in the description. Like, this has all the hormones. This has the secretory products. This has where the hormones are, even the pancreatic secretions. Like, it's always nice to link concepts together when you're studying something. Try and compare things to each other. Don't just memorize each thing, on its own. One thing that helped me is that I would say that gastrin But I got this from Medicosis, by the way. It's a YouTube channel. Gastrin is the only enzyme that likes the stomach. All of them hate the stomach. There's a lot of stuff like that that helps you remember. طيب. With that, we're done. We're completely done. Does anyone have any questions? ولا لا? Oh, good. Which YouTube channel did you get it from? Oh, I thought you knew it. Yeah, okay. Who is gatekeeping these sources from you guys? I don't know. Medicosis perfectionalis. That's literally, I'll type it in the chat because it's a pretty difficult name. طيب. This guy is one of the GOAT for GIT physio. طيب. Salaha Dr. Angelica, I didn't like her explanations that much. For this guy, he's really good at explaining like GI hormones and stuff like that. His short videos, remembers, it gives you ways to remember them and so on. If you ever feel like you don't understand GI physio that much, wallah, binge the playlist. Or don't binge the playlist, binge the stuff that you care about, which is really going to help you. طيب. Oh yeah, wallah, thank you. This is my contact information, my number, and my email. Scan this code like right now, like scan it right now. It has a quiz, 5 questions really quickly, and the feedback, طيب, so you can say what you think about this. And without further ado, thank you guys so much. Wallah. Without further ado, we're done. Thank you guys. Hour and 6 minutes, 2 lectures. I think that's pretty good. Bas wallah, thank you guys so much.